Hi guys, so today we are going to talk about neuromuscular diseases. So this is very interesting because this comprises of like a wide range of diseases. So neuromuscular diseases, they affect the peripheral nervous system and they affect the functions of the muscles due to problems with either the nerves, the neuromuscular junction, or the muscles themselves. And the most common sign of these diseases would be muscle weakness. Okay, so just to give you like a brief overview, we're going to talk about different things like myasthenia gravis. We're going to talk about muscular dystrophy, so both Becker and Duchenne, ALS or amyotrophic lateral sclerosis, and LambertEaton syndrome. So those are some of the things we're going to talk about today. So these are the different types of neuromuscular diseases, and different types of neuromuscular diseases have different causes. Most of them are either genetic or like due to spontaneous mutations or autoimmune. So let's give you an example. For instance, a genetic cause can be like a gene that's passed down through families or generations or from the parents, or it can be caused by like a spontaneous gene mutations. So in the case of for instance, Duchenne and Becker muscular dystrophies, these are like genetic conditions. Neuromuscular diseases can be autoimmune. So this is when like your body's immune system kind of malfunctions and starts attacking your own muscles or your own nerves. So for instance, in the case of myasthenia gravis. Okay, so these are some of the things that we're going to talk about today. Okay, so let's start with myasthenia gravis. Okay, so let's start with general characteristics of myasthenia gravis. So myasthenia gravis is an autoimmune condition, okay? And it causes muscle weakness, which improves with rest. So this is really key. This is like a classic presentation. It causes muscle weakness, but then after some time, after resting the muscle, it improves. Okay, the muscle weakness improves. So peak incidence, so this is really interesting because for women, it tends to affect women during their early like decades, between 20s and 30s. But for men, this presents quite later in their lifespan or lifetime. So between 50 to 70, okay? So we have this like really weird distribution of peak incidence between two genders. So just remember, myasthenia gravis, for women, it affects them between ages 20 and 30. And for men, it's between the ages of 50 to 70. And but in general, this is more common in women, okay? There is a strong link between myasthenia gravis and thymomas. So thymomas are tumors of the thymus gland. So this is another very important thing to remember. So this slide is really important. So again, myasthenia gravis is an autoimmune condition. It causes weakness, which improves with rest, okay? And peak incidence women 20s to 30s, men 50s to 70s, and there's a strong link with thymomas or tumors of the thymus gland. Okay, so let's talk about the pathophysiology of myasthenia gravis. So before we read all of this, let's remind ourselves what happens in a neuromuscular junction. So in a neuromuscular junction, you have like the neuron, and at the end of the neuron, you have the axon terminal. And at the axon terminal, or the presynaptic membrane, acetylcholine is released. And this acetylcholine travels across the synapse and reaches the receptors on the postsynaptic membrane. So it reaches nicotinic acetylcholine receptors, and they bind onto these nicotinic acetylcholine receptors and stimulate them, and then an influx of positive ions happen, and then we generate national potential, leading to a muscular contraction. So that's what happens in a neuromuscular junction. So in the case of myasthenia gravis, our immune system produces antibodies against these nicotinic acetylcholine receptors. So when antibodies are attached to those receptors, obviously these receptors are non-functional, leading to reduced postsynaptic potential and therefore reduced muscle contraction. And these muscles, they get fatigued like easily, And the more that they are stimulated, the more they become fatigued. And the more, it's written here, the muscles are stimulated repeatedly, become fatigued. And the more the muscles are used, the weaker or the more fatigue it gets. All right? But the important thing is this improves with rest, because the receptors are going to be freed up again, you know, if you rest them, and then you'll be able to use them again. So some of the strength would come back after some rest. All right. So antibodies also activate the complement system in the neuromuscular junction, leading to the damage to the receptors on the postsynaptic membrane. Okay, not only that we're producing antibodies against these nicotinic acetylcholine receptors, making them kind of not usable, because if an antibody is bound to that receptor, it can't be stimulated by acetylcholine. Not just that, it activates the complement system, which is, you know, an immune kind of response. And they start attacking these acetylcholine receptors, so they actually get destroyed in this case. So I told you about the nicotinic acetylcholine receptor antibodies that our immune system produces, but our immune system can also produce 2 other antibodies in the case of myasthenia gravis. So in 85% of the case, the immune system in myasthenia gravis produces nicotinic acetylcholine receptor antibodies. Okay? In the other cases, they produce antibodies against muscle-specific kinase and LRP4. Okay? So muscle-specific kinase and LRP4 are important for the creation and like the organization of the acetylcholine receptors. So destruction of these proteins, because they're being tagged with the antibodies for destruction, would lead to inadequate acetylcholine receptors being produced. All right. So to summarize this slide, in myasthenia gravis, in 85% of the cases, our immune system produces antibodies against the nicotinic acetylcholine receptors on the postsynaptic membrane. So this means that we have reduced action potential and reduced muscle contraction. And the more that the muscle is used, the more it becomes fatigued and the weaker it gets. But this will improve with rest as more receptors are freed up. So the antibodies also activate the complement system, which kind of like attacks these receptors and actually destroys them. 2 other antibodies are produced in like the rest of the cases for myasthenia gravis. So we can have antibodies against muscle-specific kinase and antibodies against LRP4. So muscle-specific kinase and LRP4 are involved in the creation and organization of these acetylcholine receptors. So if we destroy these, if we tag these for destruction because we produce antibodies against them, then it's going to lead to inadequate acetylcholine receptors on the postsynaptic membrane. Okay, clinical presentation. So like I said, the skeletal muscles, they become weak as you use them more and more, but this will improve with rest. So this means that symptoms are usually better in the morning and it gets worse during the day as you do more and more activities. Okay, so in the case of myasthenia gravis, however, sensation and reflexes are preserved. Okay, sensation and reflexes are preserved. This mostly affects the proximal muscles and the small muscles of like the head and the neck. Okay, so which muscles exactly? So for instance, we have our extraocular muscles in the eye, and you know, if these get fatigued, then we can start getting like changes in our vision, like diplopia. The eyelid muscle, if that gets fatigued, then we can get ptosis of the eye, or the drooping of the eyelid, drooping of the eyelid. We can get weakness in like facial movements, and then we can also get difficulty in swallowing or deglutition, because our swallowing muscles can get weak. Our tongue can also get weak, which can result to like slurring in the speech, and we can get fatigue in our jaw when swallowing. So these are some of the muscles that are affected, and this condition progresses slowly with periodic exacerbations. Okay, So again, to recap, clinical presentation, usually we know that the muscles get fatigued the more that we use them, but this improves with rest. So this means that the symptoms are usually better in the morning and progressively gets worse during the evening as more and more activities are performed during the day. And myasthenia gravis typically affects the proximal muscles and the small muscles of the head and neck, which exact muscles, so like the extraocular muscles of the eye, if that gets fatigued, then we see changes in vision like diplopia. Our eyelid, if that gets fatigued, we can get ptosis. Our facial muscles can get fatigued. Our swallowing muscles can get fatigued. Our jaw can get fatigued when swallowing. Our tongue can get fatigued, so which may result in slurring in the speech. Okay, so let's talk about physical examination. So there are many ways in which you can elicit like the fatigability of the small muscles of the head and neck and kind of worsen the symptoms of myasthenia gravis. So we know that in myasthenia gravis that the more you use the muscles, the more they get fatigued and the weaker they get. And this improves with rest. So one of the ways in which we can elicit this fatigability in the muscle can be like asking them to repeatedly blink. So repeated blinking is gonna tire out their eyelid muscles, and this is gonna exacerbate the ptosis of the eyelid or the drooping of the eyelid. So actually, quick quiz, not related to myasthenia gravis, just so we know what we've retained from last week, from all the cranial nerve stuff that we've discussed. Which cranial nerves are responsible for opening and closing the eyelid? I'm reading the chat. Yes, yeah, correct. So the oculomotor is responsible for opening the eyelid. Remember, O for open. This is because it innervates the levator palpebrae superioris, which is responsible for elevating the eyelid. And the facial nerve is the one responsible for closing the eyelid because it innervates the circumferential orbicularis oculi, and that's responsible for closing the upper and the lower lids. Okay, so remember, oculomotor to open the eyelid, facial to close the eyelid. Anyway, another way in which we can elicit this fatigability in the muscles is asking them to look up for like a long period of time. So continuous or prolonged upward gazing, looking up, is going to exacerbate, like it's going to tire out the ocular muscles. So this is going to make their diplopia worse. Okay. Another one is if you ask them to like repeatedly abduct their shoulders, if they do this like 20, 30 times, and then you ask them to like lift both arms, you're going to see unilateral weakness in the side that they've just, repeatedly abducted their shoulder. Another one that you can look for on a physical exam is a scar on their chest. So a thymectomy scar. So a thymectomy scar can tell you that they might have had a thymoma that's been removed in the past. And I told you that there's a strong, very strong association with thymomas or the tumors of the thymus gland and myasthenia gravis. The other one is checking their force vital capacity, just to check the strength of their muscles of respiration, the respiratory muscles, okay? Okay. How do we diagnose? So in terms of diagnosis, we can start with directly checking for the antibodies. So we can try detect for the presence of antibodies against the nicotinic acetylcholine receptors, and this happens in 85% of the cases for myasthenia gravis. But it can be negative as well because in 15% of the cases they might have other autoantibodies. So they may have antibodies against the muscle-specific kinase or LRP4. Remember that muscle-specific kinase and LRP4 are responsible for the assembly or the creation of the acetylcholine receptor proteins. So if we have autoantibodies against those, then we can't really produce a lot of acetylcholine receptors, leading to myasthenia gravis. So first, test for autoantibodies. Second, we could do EMG. So EMG for myasthenia gravis, we are gonna see decremental response to repetitive stimulation of the motor nerves. So as we stimulate the motor nerves more and more, basically we elicit that fatigability in the muscle. So there's gonna be decremental response to that repetitive stimulation, okay, on an EMG. Third, we could do a CT or MRI to check for a thymoma. Remember that tumors in the thymus gland are strongly associated with myasthenia gravis. And last one, we could do an edrophonium test. So edrophonium is also called neostigmine. So basically, what this does is it inhibits the cholinesterase. Cholinesterase, they break down acetylcholine in the synapse. So if we inhibit the cholinesterase enzymes, then we're going to have a lot more acetylcholine floating about in the synapse, which can stimulate the nicotinic acetylcholine receptors on the postsynaptic membrane and therefore generate more, action potential, leading to like muscular contraction. So what this does, what neostigmine will do if there is myasthenia gravis present, is it will temporarily improve the weakness, okay? But this has high false positives, right? So to summarize diagnosis, first we can check for the antibodies. So antibodies against the nicotinic acetylcholine receptors happens 85% of the cases. If that's negative, check for the other antibodies, like antibodies against the muscle-specific kinase and antibodies against LRP4, okay? On an EMG, you're looking for decremental response to repetitive stimulation of the motor nerves. On a CT MRI, look for a thymoma. You could do the edrophonium or neostigmine test, where you give the patient neostigmine or edrophonium, same thing, and this will inhibit the cholinesterase, allowing you to have more acetylcholine floating about the synapse to stimulate the postsynaptic nicotinic acetylcholine receptors, which will temporarily improve the weakness. Okay, so let's talk about treatments. First one is acetylcholinesterase inhibitors. So we have pyridostigmine and neostigmine. So what they do is they inhibit the acetylcholinesterase, which is the enzyme that breaks down acetylcholine in the synapse. So more acetylcholine present means we can stimulate the postsynaptic membrane a bit more, leading to more muscular contraction, which will improve the weakness. The second option is using immunosuppression. So we can use corticosteroids. These are great anti-inflammatories because remember, myasthenia gravis is an autoimmune condition. So if we calm the immune system down, we might, reduce the damage to the acetylcholine receptors. We can also use immunosuppressants like azathioprine. Azathioprine is an immunosuppressant. Corticosteroids are anti-inflammatories. We can also use plasmapheresis. So this is like filtering out the autoantibodies from the plasma of the patient, so that they can't, tag and attack the acetylcholine receptors or the muscle-specific kinase, things like that. So number 4 is thymectomy. So if they have a thymoma, a tumor in their thymus gland, we need to take it away because there's a strong link, I told you, between thymomas and myasthenia gravis. And the last one is monoclonal antibodies, so your IVIGs, like rituximab. So rituximab specifically targets B cells, and remember, B cells become plasma cells which produce antibodies. So if we target B cells and destroy them, then less antibodies are going to be produced. So summary of treatment: acetylcholinesterase inhibitor, pyridostigmine, neostigmine, then your immunosuppressants like azathioprine, corticosteroids, thymectomy if there's thymomas present, monoclonal antibodies like rituximab targeting B cells so that they don't produce a lot of autoantibodies, and plasmapheresis, filtering out the autoantibodies from the patient's plasma. Okay, so we need to talk about myasthenic crisis because this is like a medical emergency that happens in 15% of patients with myasthenia gravis. So myasthenic crisis is a medical emergency, and this is like a severe complication of myasthenia gravis and can be life-threatening. So with myasthenic crisis, there is an acute worsening of the symptoms that they're already experiencing, acute worsening of like the diplopia because of the tiredness of the ocular muscles, the ptosis of the eye because of the tiredness of the eyelid muscles, tiredness of the facial muscles, of the swallowing muscles, of the tongue, slurring the speech, and also tiring of the diaphragm and the intercostal muscles, which this can lead to respiratory failure. This is why this is a crisis or a medical emergency, because it can lead to respiratory failure due to the weakening of the respiratory muscles, like intercostal muscles and the diaphragm. And this is usually triggered by like another illness, like an upper respiratory tract infection or some other pathogens. So in this case, what we need to do is, if there's respiratory failure or impending respiratory failure, then we can put the patient on BiPAP just to support them for the respiratory function, or we can intubate them and put them on mechanical ventilation. Treatment would be like IVIGs or plasmapheresis, so filtering out those autoantibodies. So this is really key, guys. So again, myasthenic crisis, very severe complication of myasthenia gravis, medical emergency, happens to 50% of the patients, characterized by acute worsening of the symptoms, and this can lead to respiratory failure due to the tiring of or fatiguing of the diaphragm and intercostal muscles. What we need to do is we need to get them on BiPAP, or if that's not helping, mechanical ventilation, intubate them. In terms of like actual pharmaceutical treatment, it will be IVIGs and plasmapheresis, okay? Right, another one we need to talk about is Lambert-Eaton myasthenic syndrome. So Lambert-Eaton myasthenic syndrome is associated with small cell lung cancer, okay? And this is caused, again, this is an autoimmune condition, but the kind of different mechanism, it attacks different things. So it's caused by autoantibodies against the presynaptic calcium channels. So if we, damage the calcium channels in the presynaptic membrane, then what we're doing is we're preventing the release of acetylcholine, okay, from the presynaptic membrane, okay, to the synapse. So symptoms would be proximal muscle weakness and hyporeflexia. And this is distinguished from myasthenia gravis because when you try to do when you try to elicit fatigability in the muscle, actually the symptoms will improve with repeated muscle stimulation instead of get worse in the case of myasthenia gravis. So this is how you differentiate the two. Okay, so again, to summarize, Lambert-Eaton myasthenic syndrome is associated with small cell lung cancer, and it's also an autoimmune condition whereby the immune system produces autoantibodies against the presynaptic calcium channels, leading to decrease of acetylcholine release into the synapse. So, if acetylcholine is not being released in the synapse, then we're not going to stimulate the postsynaptic membrane. We're not going to get muscle contraction. So symptoms will be proximal muscle weakness and hyporeflexia, and this is distinguished from myasthenia gravis by trying to elicit the fatigability, and actually the muscle weakness improves with repeated muscle stimulation instead of get worse, as in the case of myasthenia gravis. So that's the difference, okay?